I would like to introduce you to our speaker, Dr. Alan Pitt. Dr. Pitt is a physician and professor in the Neuroradiology Department at Barrow Neurological Institute, Dignity Health St. Joseph's Hospital and Medical Center. He is also the Chief Medical Officer of Avizia, a global telemedicine company based in Reston, Virginia. Outside of his clinical practice, Dr. Pitt spends the majority of his time focused on practical applications of clinical informatics. At this time, I'll turn it over to Dr. Alan Pitt.
Kim, thank you very much. Looks like I'm jumped ahead there. So I want to thank the Rural Health Resource Center and Kim for your efforts to sponsor this talk. Today, I'd really like to share some of my experiences in telemedicine, but more than that, I'd like to share some of my personal thoughts around why telemedicine matters to all of us in terms of improving care, reducing costs, moving forward in America. For today's talk, I'm going to really talk about healthcare's new reality, a little bit about telemedicine, try to give you some historical context, as well as future opportunities. And I'm going to specifically focus on rural as an opportunity for telemedicine and collaboration. So why am I speaking to you? Well, as Kim mentioned, I'm a professor of neuroradiology. I am in healthcare. This is really my family business. My father was a physician. My daughter is in medical school. And I've reached midlife, and I have to say that I'm not really satisfied with the way we care for each other. The other picture that you see there is a picture of my family with my wife and my children and my mother. You may not be able to appreciate it, but my mother sitting there is actually a quadriplegic. And unfortunately, I, like most of us, have had my own experiences as a consumer of healthcare, watching her journey through healthcare. And I think we can do a far better job than what we do today. And so I am constantly looking for ways to improve the way we care for one another. So I'm also a Jew. I'm married to a Catholic, so I don't really feel comfortable in church or temple. So I'm looking for my sense of purpose, kind of my value proposition, what I can add value around. And I live under the golden rule. If you go on LinkedIn, I'm happy to link with all of you. But if you go on LinkedIn, I would tell you that I live by the golden rule. But I also believe in the tenet that every generation of humanity solves its problems through a new paradigm. And the last paradigm was the paradigm of the individual, how we optimize the individual through the computer. And the paradigm that we're just beginning is this paradigm of the crowd and collaboration. Some of us use Facebook or LinkedIn, other social media. I think that that's an extremely powerful tool that one can use actually for care. And this idea of team-based care can be enabled by some of these technologies, and then you just really started to get to the tip of this. I also believe that we've become prisoners of our own economic models. And so healthcare today is largely structured around you get what you pay for. And we need to begin to think about ways to improve care within the confines of those business models if we really want to do scalable endeavors to change the way we deliver care. So I'm always looking for ways to bring forward innovation that align with business models that make sense for scale. So most of you on this call probably are aware of this. This is we're living in the greatest change in healthcare in the last half century. So the last time that healthcare changed this dramatically was in the Lyndon Johnson era in 1965 when he brought forward Medicare and Medicaid. Obamacare is a similar change. And really that change has been brought about out of necessity. We just simply cannot afford to continue to deliver care as you go, pay as you go care. And so there's this dramatic shift from fee-for-service to value-based care, also from hospital to clinic. Frankly, healthcare is an expression of a country's culture, and American medical culture has been one of a heroic culture. We value the surgeon. We value the hero. And we're moving towards something that's much less sexy, much less heroic. It's chronic care management. We're moving to shared risk and ACO models. And it's a question, how are we going to get across this chasm, cross this bridge, and not leave anybody behind? So everyone is struggling to try to figure that out. Well, fortunately or unfortunately, if you're a hospital administrator at many smaller hospitals, larger hospitals as well in this country, change has come to healthcare, and there's a real convergence where lots of things are changing, where there's a value now placed on managing the care continuum with outcomes. And all perspectives, not only the patients, but the providers, the payers, policy perspectives are all converging for this transformation for managing care around the continuum of outcomes. This is a big change from where we have been. Now, I spend a lot of my time, I spent the last 20 years in kind of digital health, healthcare informatics, and I know most of you don't care about computers in medicine. Or if you do, it's just in passing, and how can I use that tool? So I've tried to present you here with a model that will help you at least put different technologies in various buckets so you can understand how those technologies might be something that you would want to look at as you make this transition to value. So there are really 4 buckets for me. The first bucket is data, and that's the one that gets all of the attention. Probably 95, 90%, 98% of the discussion is all around data. You have to implement an EMR. You have to get dashboards. You're probably looking at population health software to try to understand risk of your population as well as provider utilization, trying to figure out all of those pieces. But I don't believe that data in isolation is enough to get you across the chasm. You have 3 other pillars that need to be discussed and thought about, and those include interoperability, because now there's this co-opetition. We have organizations that have been competitors generally in the marketplace that now have to work together to manage that patient through the continuum, and these competitors need to be able to exchange their data. So we need to figure out ways to have better data interoperability. Personal health records are incredibly important. So for decades, we've trusted the provider, the doctor, to be the one voice for value in healthcare. But the old joke is that the surgeon says, you know, the surgery was a complete success. Unfortunately, the patient died. Technical success does not translate into a good outcome. We need to reach out to patients, begin to understand, did they see value in the treatment they got all along the way? Because many times patients do not see value for some of the treatments we do. We as healthcare providers certainly want to help wherever we can. Sometimes we're helpful. Sometimes it's a little bit overkill. And then finally, collaboration, which is what I will spend the majority of time talking about. Collaboration, to me, telemedicine, is much more than video conferencing. It involves the full suite of products of how we bring the entire care team together around that patient to enable reassurance. And I'll get a little bit more into that. As you know, an accountable care organization has to go beyond an inpatient stay, and all of these and more different spaces have to come together under a single umbrella if we truly want to manage the care continuum. Well, that means having much more robust conversations than can be provided over phone or fax, which is what we use today to have a conversation. We need to figure out better ways to talk to different organizations who are also involved in the care of our patients. So we need to figure out how to bring these 1,000 points of light together with robust communication tools. Now, when I talk about telemedicine, I watch the eyes of the audience often glaze over because, frankly and understandably, most administrators, most physicians, most providers don't really care about telemedicine. In fact, I think telemedicine is a terrible term with an awful brand that has overpromised and underdelivered for decades. What I'm really here to talk to you about is the opportunity to provide reassurance in the care continuum. And that goes for the patient, for their family, and for the less skilled provider. We're all faced with fear and anxiety when we have a new medical diagnosis. Really, what we're looking for is to have some level of reassurance that it's going to be okay, or at least it's going to be as okay as it can be. Now, what happens in healthcare today if we can't find that reassurance? We try to fill that gap with utilization. We order laboratory, we order imaging, we get consultation, we transfer patients. We do anything we can to fill that void. And so really telemedicine, collaborative medicine, is the opportunity to put reassurance back in the care continuum for all those involved and to avoid expensive utilization without much upside. We want to stop that panic button. Now, when you talk to most administrators and you say, what are the major barriers that you have for telemedicine today? They would tell you that, well, look, I can't get paid for it, and licensure is an issue. And I would tell you that payment and licensure are both an evolution, but I really don't think that those are the major obstacles, particularly as you move to shared risk. Issues regarding reimbursement are going to recede. There's plenty to do inside an individual state. You don't necessarily have to go out of state for licensure. I think the major issues revolve around having a transparent business model as to why you are providing the service you're providing, figuring out how to have scalability as well as accountability, because the roles and responsibilities of all sorts of folks change in the new world where you move off of faxes and phones and onto more robust devices such as PDAs. Now, really, why has telemedicine not delivered on its promise? And part of that has to do from a historical context. So many of you may know, but telemedicine was really birthed in NASA. They were trying to solve the problem of care for the astronauts. The U.S. had intercepted radio transmissions from some of the cosmonauts, and they had two cosmonauts who had actually been fighting in space, and they were supposed to draw blood on each other, and one cosmonaut didn't like the other cosmonaut very much, and he actually drove the needle all the way down to the guy's bone. And NASA was all worried that this would cause a mission to abort. They were looking for ways to provide health care for the astronauts, and so they began to develop early telemedicine. And access was really the issue for telemedicine. How do we provide care to the person who's afar? Now, rural is one example of that, but access became the focus of telemedicine. Fundamentally, there are many more things that we can do with this technology. The other thing was that as this technology developed, it was truly owned by a bunch of gearheads. Now, I have a propeller head in my closet as well, as I'm sure most of you do, and I take it out once a year or so. But frankly, technology people do not make the best business people. I buy the new shiny thing, and I just care about the technology for technology's sake. But what we really need to do is look at the technology and place it in some form of relevance. Why are we doing this, as opposed to strictly that it's the new thing? And so many of the people early into telemedicine were really technology-focused as opposed to business-focused. And we need to get out of that space. Now, although grants have been a wonderful catalyst for telemedicine, I kind of view grants as telemedicine crack. The problem is that you want to do the right thing, and grants are just another way of saying, you know, I want to do the right thing, but I haven't defined a business model yet. But you kind of get addicted to these dollars. We get addicted to these dollars, and we stand up programs around grants without an idea for scale. What would it look like? Why am I doing this? And so we need to think about some of the foundational finances around telemedicine, move away from grants, and begin to look at core business processes that help us stand up any hospital. Why are we enabling collaboration rather than we simply filled out a grant application for providing these services? Unfortunately, a lot of times, you know, day two, the day the grant money runs out, there's no money left to support the program. Now, when we think about telemedicine also, I want to be sure that you all understand that telestroke, which is probably one of the more visible applications of telemedicine, is an example of collaboration. It is not a collaboration strategy. And in fact, many people in rural America are really on the outside looking in. So telestroke, the main business model behind telestroke, particularly for tertiary hub hospitals, is a referral model. They basically want to suck patients from the margins into tertiary hospitals for advanced surgeries and other things. Now, this may solve the problem of increasing the level of care for the patient at the periphery, but this is not core business for most people engaged. So, for an example, I work at a large neuro center, and we, for many years, have had one person involved in telestroke. We have 55 people every day who wake up and look at length of stay at our hospital. I think for collaboration to truly scale, you need to begin to think about how collaboration addresses core business processes and helps them improve. You know, hospitals put their money where their mouth is, right? 55 people means that's a core process. One person for telestroke, not so important. Now, I know I got involved with the Rural Health Resource Center many years ago through a friendship I developed with Telehealth and others. And I recognize that rural hospitals are under tremendous duress. In part, this is a branding issue. Most people will go to their local rural hospital for primary care. But as soon as they have issues that they consider to be of increasing complexity, they tend to do what I call the rural drive-by. They get in their car and they just blow by the rural hospital. This is much quieter, but equally as deadly to the urban drive-by. Rural hospitals need to figure out transparent ways to develop effective partnerships where their patients stay rural whenever possible and only go to the city when required. And I think that's possible through collaboration as well. Those branding issues have to be a back and forth, however. The local resident has to feel that they are getting as good or better care locally than they could if they got in their car and drove to the city. And I think we can do that. Now, as Kim mentioned, I'm a practicing clinician, but I also play a role as a chief medical officer for a telemedicine company. And one of the things that I struggle with is the conversation with rural America is very difficult. Selling to rural America is a very fragmented sell. It's very expensive. And so for people to have a conversation around how to improve the level of service delivery, it becomes very expensive to have a conversation with rural America. And I think to overcome this, rural America needs to think about how to aggregate themselves and speak with a much larger voice than single hospitals. I think the idea of rural networks is a very important one in terms of upping your ability to adopt new technologies. You have much more leverage as 5, 6, 10 hospitals coming together to speak with one voice with common problems. You can go to vendors, whether it's an EMR or a telemedicine company, you can speak with one voice and have much more leverage than you can as isolated islands, small hospitals, which each need their own conversation. Now, some other things that rural struggles with that are unique to rural are that generally people who are very deep in technology tend to live urban. They don't tend to live rural. So I have had scenarios where people could get technology, but they will look you straight in the eye and say, look, it's great if I get this technology. I just can't find anyone to manage this. So in order to have a scalable solution, you have to think about, day two. What does it look like for support? And I think it's necessary to begin to think about what that looks like and how you do that from a cloud-based model as opposed to on-premises support. And so that needs to be thought through. Now, when I mentioned telemedicine and opportunities that are different than what we do today, I want you to think about this diagram. So the majority of telemedicine discussions have revolved around the left side of this red line, this idea of referral, this idea of remote access, stroke being the primary example. When you have a conversation with an urban hospital, most CEOs, most CFOs, they kind of glaze over for things on the left side of that red line. And the reason is that that's new business to them. They know that they should be addressing it. They want to be thinking about new business, but really they wake up every day and they're focused on my business, their business, the business of running their hospital. And so there are issues related to the minute that patient hits an emergency room door, through that hospital stay with length of stay, all the way through to home, that can all be addressed through collaboration. That is the day-to-day core business of any hospital, whether you're urban or rural, that can be addressed with collaboration. So I'm going to kind of focus on some of those use cases as opposed to the more traditional ones of stroke and rural access. Now I want to give you a little bit of a framework to think about telemedicine as well. So telemedicine as a space is incredibly busy. There's probably no space in healthcare where there's bigger change ongoing today. And so as a hospital, as an administrator, as a clinical champion, you need to be looking forward toward a collaboration strategy that will help you care better for your patients. As you begin to look at the offerings inside the telemedicine space, you want to look at them carefully and decide, is this offering a business-to-business offering, or is it a business-to-consumer or customer offering? So, for instance, much of the discussion in the telemedicine space is focused on these online urgent cares. And that's really a business-to-consumer opportunity as opposed to business-to-business opportunity. I'm frankly more interested in the business-to-business opportunities, how we bring rural and urban together, how we change the fundamental business processes of a hospital through collaboration. Other telemedicine offerings are typically, they fall into one of two things. They're either technology or they're a service offering. So a technology might be someone who comes and says, look, we have carts and we have software and we'd like to enable your physicians to better care for patients on the ground, or your physicians to interact with other physicians. Alternatively, you may be offered a service offering in the space as well. Specialists on call would be a primary example of a service offering. In this case, a vendor comes in and says, look, we believe that you need gap coverage for something, whether it's telestroke or behavioral health, something. We have not only technology, but we have physicians. We want to provide this coverage for you on some sort of monthly fee where we'll do the whole thing soup to nuts. You want to look at a telemedicine offering and decide, is it predominantly a technology where I'm going to be asked to provide the clinical care, or is it a services offering? Now, when you start to begin to evaluate telemedicine, unfortunately, we tended to do this backwards, and there's really three stakeholders that need to be identified for telemedicine. Unfortunately, for the most part, in many cases, IT has been the champion for much of telemedicine. And this is really backwards. I think any successful program starts with a clinical champion first, who then enlists administrative help in terms of budgetary, writing a business plan, all those sorts of things. And IT should really be there as an enabler. Once you've defined a clinical champion, a business reason for doing this, then the question is, how are you going to do it? I've also lived long enough that I've seen the evolution of the electronic medical record. So when I was in medical school, everything we did was on paper. Orders were filled out in triplicate. We used to have these yellow sheets of paper. You'd write notes in. And you'd go on rounds and you'd meet some early adopter person there, and they'd have an Excel spreadsheet of their patients, and they would be extolling the virtues of this technology. And it seemed every department had somebody like this. And hospitals soon realized that you couldn't have 15 or 20 different repositories for patients throughout the hospital, and that led to the evolution of the electronic medical record. It wasn't as good as a solution strictly dedicated to an individual department, but it was good enough so that you had a platform as a service instead of individual verticals. I'm expecting to see the same thing to happen in collaboration over the next 5 to 7 years. As you begin to evaluate telemedicine collaboration, you want to have an eye towards a single platform that will suit your needs, soup to nuts from beginning to end, because otherwise your core IT people are going to be stuck with secure messaging and a telestroke program and a behavioral health program and an e-triage program and all of these things, which will lead to multiple applications, all to deal with collaboration. You need to begin to think about, how have an organized way to do this. With that, I'm going to kind of address some concrete use cases that might be of value. So one of the things, when you look at the pillars that you need to look at to set up a telemedicine program, they really fall into 4 basic categories: software, hardware, networking requirements, and people. Each one of these should be thought about, but fundamentally, it should not fall to the rural provider to have to stitch these together. And you really want to ask, how is this being done for me so that I don't have to take care of these little pieces? Any hospital, whether rural or urban, their job is to take care of people, not really to stand up technical solutions. I call out people as separate because, again, this can be very variable. This can be local providers, or it can be people gap coverage. Now, I kind of joined this company, Avizia, because I wanted to make a change, a real difference. And I don't really want to see stuff being put forward in the marketplace that just sits in the corner. And some of you, gosh, I hope it's not many of you, but some of you almost certainly have a cart sitting there gathering dust. And the reason that you have a telemedicine cart gathering dust is that it was led often by IT without clinical buy-in and without a business case. To avoid one and done, it should start with clinical, go to administrative, and then go to IT for support. What are the components of a platform as a service? There are really 3 components. The first layer is messaging, and as some of you may know, secure messaging is now a federal requirement. As of September of 2013, HIPAA information cannot be sent through phone texting, and so every hospital has to adopt some form of secure messaging, some form of secure communication between physicians and physicians, and between nurses and physicians, or hospital unit clerks and physicians. And so you're seeing a rapid adoption of secure messaging. Notably, secure messaging is not as simple as you think because it has its own rules and social norms that fit into that. So physicians are willing to receive messages, but only from certain people at certain times of day. And so messaging platforms need to take in the cultural context of how we want to receive messages. Many of your physicians are unwilling to receive direct messages from folks unless they're on call, or they still want you to move through their call center. It's actually a pretty complex space. So messaging is all about provider-to-provider secure communication with a layer of cultural norms. The next layer to set up a collaboration platform is navigation. And that's really provider to patient, but the provider in this case is an evolving role. It's the nurse navigator. It's the person who makes sure that you keep your doctor's appointments, makes sure you keep your scripts. They're not operating on you. They're not filling drugs for you, but they're helping connect you back to the right person at the right time. And then the final layer is a care layer. It's a provider-to-patient layer where you basically are caring for someone. You're evaluating them. You're writing a script for them. You may be asking them to come in for surgery. You're establishing much more of a traditional relationship with a doctor-patient, but you may be doing it in the cloud. In an ideal world, to truly come up with a collaboration strategy, you need to have all 3 of these components acting in concert, kind of like Microsoft Office, where each component speaks to the other, and they're not individual applications that have to be managed by your IT shop. That becomes unwieldy. So give that some consideration as to how these various components fit together to come up with a collaboration strategy. Now here's one example of my hospital and what we did moving forward. So we had a problem in that we had, like most hospitals, something like 60 call calendars that were being updated on a minute-by-minute basis and then being passed around the hospital at around 3 p.m. And these call calendars define the responsible physician for different services. And so, you'd really hope that the calendar would be accurate. And once you found the calendar, you would page the person, you might call their call center, and you'd go from there. Unfortunately, of course, physicians are notorious for not agreeing to stick by the call calendar, and they were constantly switching things. So this was a very laborious process that took an FTE for us really to manage these call calendars so we could figure out who to speak to at the right time in the right place, and we were using very old technology. So we migrated to, that's interesting, there was a graph that's supposed to show here that I don't see. We migrated to a secure messaging platform back last year, and what the graph showed, which has disappeared, is a relatively slow adoption of this secure messaging platform. And what I would tell you is that as you migrate from phone and call calendars and call centers, you're going to need strong physician leadership because you're really changing the roles and responsibilities of all those involved. So we had relatively slow adoption. Now, Dignity Health has now decided in the last 2 months to take this out more broadly, to take it out to the enterprise. And the biggest lesson learned is we need strong leadership from the chief medical officer, from the chief nursing officer, to take this out to our medical staff, to explain to them why they need to adopt these new mobile strategies to improve care and reduce costs. But it takes strong leadership. It's much less about technology and much more about leadership in terms of adoption. Here's another example of collaboration. And this use case was lent to me by my friends at Banner Health. And so Banner Health has stood up a EICU for many years. They started in 2006. They believed that by having someone over the shoulder, they could improve care and reduce costs. And they moved to set up a full-blown EICU. And as you can see, each year they've been able to get people out of the ICU faster than the previous year based on this EICU. They're now managing over 600 beds through their 2 command and control centers. And they would tell you that they've also saved lives using this technology and saved money as well. This is back from 2002. Deb Dahl, a good friend of mine, lent me this case, and she says that they now save something closer to $90 million a year based on the number of days in the ICU per admission, and they've also saved lives based on their predicted Apache scores. They would tell you that their outcomes are better, and I challenged her, and I said, look, if your outcomes are better, have you gone back to any of your insurers and asked for a rebate? And she says, well, as a matter of fact, we have. And we were able to shave our premiums by $1 million because we had fewer complications. Well, it's great to have technology, and it's great to save lives. Can you personalize it? And she said, well, in fact, I can. I can tell you a story. And so here's a story of a patient who was being taken care of in Fort Collins, Colorado. And the patient wasn't doing well, and all the parameters in the Phoenix Command Control Center, so the patient wasn't doing well. They reached out to the physicians on premises, and no one was available. Everyone was in the OR. The only person they could find was this intern. It was his first day. It was July or his first week. And they said, son, we're gonna teach you how to put a chest tube in. And they said, okay, we're going to talk you through it. And literally they talked them through putting a chest tube in. The chest x-ray showed some increased lucency on the left side, what you would hold up if you held up your right hand on that side of the chest. You can see it's a little more lucid, and that's air trapped in the lung. This intern had to put in a chest tube and save this patient's life remotely. So kind of a big deal with collaboration. So post-discharge care is a very interesting opportunity for rural in particular. And so there's been some very interesting models coming out of Mayo Clinic most recently. Mayo Clinic was chastised because they were partnering with rural hospitals in Minnesota, but they really weren't doing as much as they should have done to stand them up. And so what Mayo did was they went around and educated rural hospitals and their networks in terms of how to manage post-discharge care. And in this way, leveraging the Mayo model, patients who had had surgery at Mayo were able to go home earlier and recover instead of at a local urban SNF in the rural hospital. And what Mayo was able to show was that they had better outcomes, higher patient satisfaction, improved revenue both for Mayo as well as the rural providers and hospitals. Now, what were the barriers to scaling this? The barriers to scaling this were the ability to educate all of those rural hospitals. And we're exploring ways to look at how to leverage telemedicine as an opportunity for education, re-education, and care to scale these models. But I would encourage you to begin to look at this Mayo model, and I can send you references on this, about how they were able to replace SNF care with post-discharge care locally. Here is another example, and this is a picture of my father. As I mentioned, he's also a physician, and this is in 1963. In 1963, to subsidize his income, when he was an intern, he used to make house calls in Center City, Philadelphia, and he'd carry his black bag around, and he would go and see patients, and he'd have all the things he needed in his black bag. Today, with the growth of drugs and information, there's no way that you could carry all you need in that little black bag. And personally, I believe that that little black bag has been replaced with the iPad, which is unlimited people and unlimited information that you can take with you as you travel into the home. And so here's an example of using collaboration into the home. Hospice of the Valley is one of the largest hospice providers in the nation. They were beginning to see more and more palliative care patients, and they began an outreach model in 1998. They developed a medical home model in 2010 that then grew into Arizona Palliative Care Services. They were struggling with the problem of delivering care to the home in a cost-effective manner. And so what they did was they armed social workers who were making home visits with technology and an iPad to go into the home, look at the pantry, look at cleanliness, visit their charges, but then to bring in Hospice of the Valley providers, doctors and nurses, on an as-needed basis. And just doing this simple thing, they were able to reduce hospitalizations and reduce ED visits by over 50%. They were able, and notably, a physician visit to the home was measured at 2 hours and 45 minutes. And in this case, physician visits were something less than 10 minutes. So you can see the cost savings involved. They were able to resell this program on a PM basis to one of the insurers here, SCAN, and they're looking at ways to make this part of a larger opportunity to resell PM contracting for in-home visits over collaboration. What are some of the opportunities that you may want to look at locally where collaboration might help you in your marketplace? So on the left side there, I have put remote care opportunities, and I'm certain that you are going to continue to pursue those. Again, I would mention that it is important to begin to look at tertiary providers as partners, not to have this sucking sound where they're taking your patients and you don't see that patient. They need to become partners. I think there are internal opportunities for rural hospitals, just as we are seeing with urban hospitals, to improve efficiencies for the care of your patients locally. That goes from the minute they hit your emergency room, like I showed you with that triage, through length of stay, all the way back to home, where you can improve the shared risk opportunities of caring for those patients through collaboration. Two other opportunities that are probably worthwhile calling out that we're seeing nationally. One is schools as an extension clinic. To me, it makes no sense that children who often have chronic conditions are taken out of school, the parent has to miss work, there's absenteeism, there's lost work, and often these children either get insufficient care or end up in the wrong space at the wrong time. They end up in urgent cares and emergency rooms, which is not really what we want. And so I believe schools should be viewed as an extension clinic where much of the polypharmacy for many of our children could be delivered in a timely fashion. We're seeing rapid growth of schools as extension clinics as a source of care. Particularly the Dallas County School District is going to basically be lighting up all of their schools in a way to deliver a higher level of care. I think this is a perfect application to be looked at. Behavioral health is also an opportunity. I think this is a very expensive problem, and particularly for rural. You have many of our former military who've returned home. They cannot find the services they need locally, and unfortunately, some of them go on to hurt themselves and hurt their families. We need to look at behavioral health more broadly because it's an ideal opportunity to look at through the lens of telemedicine and collaboration. Here's an example of behavioral health deployed. These are some of my friends at Fairview, just down the road from rural centers, and they were able to show through a telemedicine application, almost a Match.com, that they were able to markedly improve the care of these patients while reducing the cost and structure as well. So what would be a roadmap to begin to look out in terms of starting down the road of collaboration? First, I would strongly recommend that you look to join a rural network. I think it's very important that you come together with others of like mind. I think your voice is much stronger. I think you can demand different pricing structures from vendors to help you on your way. I think you need to define a business case. What can be improved in the care for your patients if you're able to improve that reassurance? What are your big problems where you have high utilization that really just need someone with a greater knowledge set to provide that reassurance? Begin to partner with these tertiary centers, but when you partner with them, you should be asking on the front end that patients stay local whenever possible. And that includes opportunities like infusion centers, imaging, post-discharge care. All of those are important opportunities for revenue locally. Grants are catalytic. They're not sustainable business opportunities. You can use a grant to start a conversation, maybe to lay the groundwork, but you need to have a sustainable business opportunity if you really want to scale what you're doing. So in summary, value-based care is really going to require a brand new business model. A lot of the reimbursement issues, I think, are going to diminish in importance. I think collaboration is really going to rise in its value to help you enable some of these newer business models to help you manage the continuum. I would strongly recommend as you begin to explore these opportunities that you look at platforms rather than simply one-offs, verticals for collaboration. And finally, networks, as I mentioned, should be a real requirement to have long-term conversations. I think it's an opportunity to really redefine what rural care should be about through collaboration. I think every citizen should deserve the best possible care no matter where they live. And I think these type of collaborative technologies offer that opportunity where geographic obstacles can really be addressed. And I think these can be done in a sustainable way. So with that, I'm going to stop and see if we have any questions.
You may press star 2 to unmute your line, or you can type a question into the chat box on the top of the screen. Dr. Pitt, if a hospital hasn't done any telemedicine, where is the best place to start?
I think the best place to start is a business problem. I think if a hospital hasn't done anything, they should look out broadly and they should say, if I could enable collaboration, what problem would I solve that I know I have direct dollars tied to? Second to that, they should then look out and say, do I have a clinical leader that I can partner with on that opportunity? So you may decide that you have a big behavioral health problem. But if you don't have clinical leadership, either locally or remotely, who wants to partner with you on that problem, you're probably going to fail, even though it's a big business problem. I would start with things that you think you can succeed on, both from a business process as well as from a clinical leadership position.
Thank you. And how do I convince the leadership that we need to get going?
That is really tough. But I think what you need to do is you need to show them the dollars. My CEO, I think sometimes when she sees me coming, I think she looks for the nearest exit. I think it's important that those who believe in collaboration take it upon themselves to try to come to their CEO, come to their CFO, knowing that they have their own challenges, and connect the dots for them as to how the dollars are flowing and how this would matter for the organization long term. I think strictly to come and say, you have to do this for me. People are dying. Okay, I get it. It's the right thing to do. But the CEO, the CFO knows that there's lots of people who need care. They need to keep the lights on. So if you have something you want to get done, think about it from the perspective of the person on the other side of the table. How are you going to solve this problem in a scalable business perspective, not only because it's the right thing to do?
Dr. Pitt, what are some of the best external opportunities to start with?
Well, I think it depends on where you are, how far you are from other urban opportunities, and somewhat the size of your catchment and what you're dealing with. I think I would really like to see school-based healthcare pushed in many locales. I think this is a natural, whether you're urban or rural, where you can improve the care of students and teachers, leveraging bandwidth that is often present at the school that may not be present in the local community, providing extension clinics during day hours rather than nighttime. So I'm very high on that opportunity. I'd like to say that behavioral health was a great opportunity. I think it's a national emergency in many ways. Unfortunately, reimbursement for behavioral health has been somewhat poor. I think the post-discharge opportunity is also one. I was very impressed with the data from Mayo, and I think that that is an excellent place to look to see if there are partnering opportunities with tertiary providers where you might be able to get those patients back in your community sooner, garnering revenue based on the swing beds, as well as providing higher patient satisfaction. Nobody wants to recover in a skilled nursing facility. They want to recover with their family.
Are there any other questions for Dr. Pitt today? What about internal processes? Where would you start there?
I think for internal processes, I would look at the call calendars and how you have the folks on premises interact with each other. Are there delays that you're seeing in your emergency rooms where people are waiting longer than they should for specialty consultation that could be dealt with improved messaging opportunities? I would note that you may get some pushback from some of your physicians. We all like to think that we're going to be available, but when push comes to shove, you know, the pager is an adult version of the dog ate my homework, right? You'll find occasionally physicians will say, oh, my pager never went off, and there's really no transparency that that happened. I think we're going to have to move to a place where transparency is king. I think if you're looking to get specialty services that help you triage to decide whether that patient can go home, needs to get admitted, or needs to go to the OR, that there's a definite opportunity there. I would also note that that same level of messaging might tie directly to your pharmacy. So for instance, pharmacy messaging is a constant problem in many hospitals where they're trying to figure out orders and get them fixed. Pharmacies are constantly chasing physicians, and you could look at these internal processes of communication and collaboration, and there's a lot of fat on hospitals. You know, you have to imagine that if the best way you have to communicate is a pager, then you got a long way to go to improve communication.
You mentioned joining with others to buy in bulk. Do you have some ideas there?
I do. You know, you have many folks around the country who have been coming together to form larger networks. Some of these out of Nevada. Cherry Hill has been instrumental in kind of locating the owners of these networks. I think it's important to look around and have a conversation with other natural partners that may come together for a network ask them how many of them are struggling or could see opportunities for collaboration, and then come jointly together with a business plan around putting a collaboration platform together, and then having the vendors compete for something. That's a much more viable opportunity than waiting for whatever technology shows up at your door. I think you tend to get, frankly, I think you tend to get not the best of breed with that approach. And I think you're much better off to some degree buying in bulk. I can tell you, because of my other hat, having a conversation with rural America is a very difficult, very expensive business proposition. And so many vendors tend to talk to rural only when there's excess time. And there would certainly be interest in having conversations when the buying opportunity was larger. I think there's opportunity on both sides of that equation. I'm sure that Rural Health Resource Center probably has a list of many of these networks throughout the country. You really have been excellent as a broker of these networks, frankly.
Thank you. Thank you, Dr. Pitt. Sally Buck, are you on the line? I know Sally wanted to mention that we have a slide up here about telehealth resources. So check out those links